Hello, welcome to the latest podcast series. My name is Lee, and today I'm joined by
Zoe Pearce, Discharge and Patient Flow Matron, Barnsley Hospital.
And I'm Jacqui Howarth, and I manage Right Care Barnsley, which is the integrated spa.
Brilliant. Thank you so much for joining us this afternoon. I suppose to put a bit of context, so we first met a few years ago when we started looking at some of the home first pathways and some of the stuff you're doing around SAFER. And it's fair to say you were doing some really innovative stuff as a team back then. And we briefly kept in touch across the last couple of years at various different touch points to see how we're going. And recently we had much more of an in-depth discussion. And I think it was fair to say, I think all of us were really impressed with what you've been doing around discharge to assess, and in particular Pathway Zero, which we thought would be quite useful to share some of that with the others. So if you, is it worth doing a bit of a brief overview of what you've done?
Yeah, that's fine. So I'll just start with a brief overview of discharge to assess in general. So obviously we had to develop this quite rapidly. What we wanted to do was we had previously tried discharge to assess, and we'd not been very successful at it previously, but we all knew that we wanted to do it, so we wanted to make it work, and I think this gave us the push to actually just go on and actually do it because we had no choice. We developed a project structure for discharge to assess, and we fed up through our gold community meeting, which had our execs on, but also community and social services execs sat on there. We developed a steering group, and then we developed some work streams. What we did when we looked at the discharge to assess guidance, we wanted to change it ever so slightly because we wanted it to meet our patients' needs in Barnsley. So we actually developed 7 work streams. For each of those work streams, we identified a lead to lead on those, and they had a clear work package with clear objectives to work through. So the way that we broke it down in Barnsley was Pathway Zero with a follow-up phone call that we're going to go on to talk about. And then Pathway 1A, which was just patients that were identified as a social need, and our social team moved quickly out into community and did all their assessments out based in community in patients' own homes. Pathway 1B, which is the therapy reablement pathway. Pathway 1C, which was for fast track patients, and Pathway 1D, which was for nursing and any medicines management issues for patients. And then the Pathway 2, the intermediate care bed base and discharge to assess beds, and then Pathway 3, the permanent placement patients. So that's how we decided to break it down, just so we could ensure that we met the needs of our patients within Barnsley. From this, we've been really successful at reducing some of the historic delays that we've had, and obviously patient feedback is really good.
Fantastic. And I don't know the answer to this. Did it cost any more money?
So no, not to start with. We have worked with what we've got, but we have just had some investment into our therapy staff, and that's to look at early intervention and increasing our slots within discharge to assess slots within community Pathway 1B.
Brilliant. And so we're really impressed about the Pathway Zero and just exactly what you were doing around Pathway Zero. So, Jacqui, what did you do around there?
So the COVID-19 hospital discharge service requirement document came out in March. We quickly implemented all the changes in the D2A pathways, and we implemented the post-discharge safety netting calls, and we managed to get those up and running on 6th of April. And the aim was just really, as it said in the document, to increase confidence around discharging due to the very rapid and very big changes that we'd made to the usual processes. So patients discharged from hospital on Pathway Zero will try and contact them the next day after discharge. We don't pick up patients that have been discharged on the other pathways, so the pathways 1 to 3. They're not included in this because we know that there's other health and social care teams that are supporting those patients after discharge. and health and social care professionals are able to seek assistance through right care and integrated SPA if they find any unmet needs, whatever's identified from their visits. We've also excluded SINS patients that are being admitted to virtual wards because these patients are getting their follow-up phone calls from virtual ward teams, and we were really careful that we didn't want patients to be getting multiple phone calls from multiple teams. We didn't want to be annoying, we want to be helpful. And the virtual ward staff, they can, if they identify a need, or if they need a referral onwards to a community or social care service, then again they can come back through SPA to refer to us, and we'll do that for them. We do aim to telephone patients once after discharge, but there have been on a really small number of occasions for a small number of patients where staff have arranged to follow up, make a further follow-up call and ring them again. It doesn't happen very often, and they do that with agreement to patient. I suppose that might be if they've had a conversation, and more often than not, it's been when the patient's been saying that everything's fine, but they've just got sort of, that niggling feeling that actually they might be struggling a little bit, and they've just not disclosed it. So when we first set up the Wear a Script that we implemented, and that was very much about advising the patients about shielding, how to get help and support from local authorities if required, and signposting them onto other services. The script we adjusted as the situation's changed over the last 15-16 months, and we've also adjusted it depending on what group of staff are actually making the post-discharge calls.
Yeah, and so who actually makes these calls then?
So initially, the calls were made from non-clinical staff from the hospital's Healthy Lives team. So these staff at that time were asked not to sort of do their substantive role, which were walking around wards, sitting, chatting with patients, and doing the health advice. So they actually approached us initially and asked what could they do to help, which were really useful. And in the first few months, the nature and the inquiries and concerns raised from patients, it was very much COVID related, and hence the script giving advice on shielding and local authority help. Over the time, sort of between April and mostly when we got up to July 2020, the nature of the queries and concerns from patients had become more clinical in nature, and we also had recognised that around that time that there were an increased amount of mental health related issues that were coming up on the phone calls. The non-clinical staff had always been supported by the nursing staff in the SPA, and we found that they were increasingly having to ring through to nurses for advice and support. So at that time, that's when we made the decision that it should be the clinical staff that are making the phone calls. So from the end of July last year, it was actually the registered nursing staff in Right Care SPA that took over making the calls, and they've continued to do that ever since.
Yeah. And so you must pick up quite a few different needs of people from the more common ones to some of the more bizarre, I imagine. What do you do if you find one of those unmet needs?
Well, my nurses will make the onwards referral, and that can be to any other service. If we don't deal frequently with a service, we normally can find out by talking to colleagues from other organisations and other services to identify the correct service. So it has happened. So some patients have expressed difficulties with activities of daily living. They've not experienced it prior to being in hospital, and they've certainly not raised it to anyone or any concerns at the point that they were being discharged. I think, nationally people noticed that people wanting to get quickly discharged from hospital at that time. So for those types of patients, we'll refer them on to neighbourhood rehabilitation service for assessment, and they've got OTs, physios and nurses within that team that can go out to patients' home and do an assessment, and then we'll get the necessary care and support in place. Feedback from nursing staff is that the most frequently identified queries and issues are medication related. So we have had to refer some patients on, quite a few, to district nurses for just some initial support, or even to medicines management service. Sometimes, and more often than not, it's just been that they've needed some explanations from the nurses about the reason for the medication, the importance of taking it, and taking it as they've been instructed. I think we're really fortunate in the system and in the Barnsley Place response to COVID discharge requirements. We've worked with the leads from all as partners in community and primary care, CCG and local authority, and they were happy to support us with all elements of discharge pathways, and that included anything that we picked up from the Pathway Zero follow-on calls. And we'll prioritise patients according to the need identified and the level of urgency. So if there is an urgent response required, community and social services will react accordingly. And what we do at the end of every call, we will say to the patient that, if they develop any problems in the future, to contact the GP. So we're trying to sort of encourage them to use other services than the ambulance and ED. And we also give other useful sort of contact numbers. So it might be for, adult social care, or it might be for the local central call service, whatever we've identified really that the patient might need going forward.
Fantastic. And so there's lots going on there. So what have you seen? What's been the impact of this so far, both at almost an operational level and at a patient level?
Yeah, so the nurses will have to, sometimes up to 90 calls a day, and that depends obviously on the previous day's discharge activity from hospital. It can be really time consuming. My nurses don't like phoning patients blind, so they'll obviously investigate any information that we've got available to us on EPR systems, and they'll do that before they start the calls, which I think is entirely the right way to go about it. There have been occasions where there's been very serious situations that they've discovered on the call. So just one instance of that, where a gentleman who were really distressed, he claimed to be in the process of taking his own life. He even described how he was going to do it. So we had that staff member actually keep the patient talking, keep him on the call, while another colleague organised an urgent response from community mental health crisis team. That sort of made it clear to us that there's a need for a clear escalation process in an emergency. So the staff now have the urgent and emergency numbers on standby, just in case they come across that kind of thing. The nurses, what they express is that some of the calls can be really lengthy. Patients, particularly those that are on their own at home, they seem to like the interaction, they want to talk, and the staff find it really difficult to speed up the call or even wind it down. And they've all said that in situations like that, they wish that they'd got longer and they could spend longer chatting. And on the whole, I think the patients have been really grateful to receive the follow-up call. There've been lots of questions asked about information that we know it's information that's routinely given to patients at point of hospital discharge, but they're often asking for clarification. So it could be things like, when is my follow-up appointment, or when is somebody coming to get my sutures out, and that kind of thing. There have been occasions where we found things that have been missed. so district nurses might not have been booked, or there might be a piece of equipment that's missing. Thankfully, this has not happened often, and it's been quite easy for us to resolve because it's the integrated SPA team nurses that are actually making the calls, so we're in the right place, and we've got the right knowledge to pick that up. But I think the biggest thing is that we've not noted any major concerns with regards to the hospital discharge and the policy or the D2A pathways that we've implemented. As I've said, we're working very, very differently than we were pre-COVID, and the speed at which the new policy were implemented and the fact that we've not come across more problems, it's been really reassuring, and it's given us confidence in the D2A processes and the pathways that we've put in place, which has been great.
Brilliant. I think one of the things I struck me when I was up with you guys was just the level of innovation and general sort of learning and that sort of QI mindset you've got. And I think you've described it really, really well, how the model's evolved so far. Yeah. It sounds like some really exciting things. So what are the next steps for this?
Well, we are reviewing the service now, so we know that we definitely want it to continue, and it will continue. We're obviously looking at the outcomes, and I'm taking feedback from all the staff that have been involved. So locally, we've gone for the follow-up calls approach, but we're thinking that for some patient groups from some areas of discharge in the hospital, that it might be better for a person-initiated approach that's also described in the discharge policy. So is it better that they're given our number for them to contact us if they want advice? And we need to look at sort of if there's additional resource, if any, required for that. There's kind of a 50-50 split with the nursing team. So half of them are very much of the opinion that the calls that could be made by non-clinical or unregistered staff, they could make the initial phone call, and if they identify that there's a need for a nurse's input, that they could transfer the call across. And then the other half of the nursing staff think that it's absolutely got to be a registered nurse that makes those initial calls, and that nurses are more likely to pick up on the subtle signs that you might need more leading questions, and you might need to unpick to expel concerns or problems that probably otherwise the patients wouldn't disclose. It's doable whichever way we do it in the department, because we have got the clinical and the non-clinical staff on duty at all times. So the passing of the calls between the different staff group, that could be an option. A few of the members of the team have asked for a more structured approach, so down to how many times do you try calling someone if the initial call's not answered. My opinion is that you can tell to a large extent from the information that we've got available from EPR and the discharge letters and that kind of thing, if some of the follow-up calls are likely to be more beneficial than perhaps to others. And so we've also implemented at the hospital a readmissions risk and a predictor tool. So obviously, if someone's got that higher risk, then it might be that we try a few more times than just the ones to contact those patients. So we are considering whether there's certain patient groups that we could perhaps exclude and use the person-initiated calls. So the obvious ones like the elective day surgery, patients that are otherwise quite young and quite well. Some of the staff feel like they're very much having to rush the calls due to the other workload, and some suggestions that it might be beneficial to have a team that's dedicated just to the post-discharge calls. And we're well aware that we've not yet explored voluntary services input, and it's definitely something that we will do over the coming week and months. But whatever it is that we decide, we'll be taking patient feedback into account. Like I said, most patients have been really pleased to have been called. even if it is to, you know, pass on the thanks to the ward and the departments, the teams, what care received while they've been in hospital.
Fantastic. That sounds absolutely amazing, and such an amazing story to hear fed back so eloquently. So thank you very much. I think it's just going to go back to right at the start. I think it's probably just worth knowing for everyone watching that this is part of an overall discharge to assess transformation, of which I know you've also written us up a case study for. So if you're interested in seeing more about what's going on in the Barnsley system, then do look up for the Barnsley case study. But I think the bit that really attracted to me, I think again you've just highlighted really well, is the safety netting was part of the initial policy, but I think it's a massive policy implementation gap across the country. I think there's very few systems doing the stuff that you're doing. So thank you for everything you're doing. Thank you for sharing this so generously. And probably not much else to say apart from thank you everybody for joining us today, and look forward to seeing you again soon.